Hey everyone, John Lesnick with Hooks of Hope coming to you live from Vero Beach, Florida here at the Hooks of Hope Tackle Room. I'm here with Dr. Brett Haake. Brett is a near and dear friend of mine. He's also associated with Hooks of Hope. He's a cardiothoracic anesthesiologist. He is a regenerative medicine specialist as well as a functional medicine doctor. He has an absolute passion for people. He has a passion for science, a passion for medicine, and also a passion for the communities that we serve. So at Hooks of Hope, you know, our core audiences really exist kind of around helping veterans and children and also their families, you know, heal from traumatic experiences, from things like PTSD, from critical illness, from whatever it may be that they're dealing with. So Brett, really appreciate you being on today, man.
Thanks for having me.
Yeah,
Excited
man.
to be here. Thank you.
Yes. So we've known each other a long time, but how'd you get into medicine?
Oh man, that's a long question, or that's a loaded question, I should say. My first name is Brett, B-R-E-T-T. So I'm from Southern Illinois, but I was born in Kansas City. And my dad named me, I was born in Kansas City in the 70s. My dad named me Brett because he named me after George Brett. So I came from a baseball family from the time I was little, and from the time couldn't even remember, I wanted to be a baseball player. I didn't want to be a doctor. I wanted to be a baseball player. So I played college baseball played all 4 years. I was pre-med. I majored in chemistry. And then after college, played a little bit in the very low levels of the minor leagues. And after doing that for parts of 3 seasons, I figured out very quickly that I needed to, or maybe not so quickly, but I eventually figured out that I needed to find a different way to make a living. And I grew up, my father was a physician, and I was pre-med in undergrad, and I had majored in chemistry. So I went back and took the MCAT and was lucky enough to get a decent score on the MCAT. And so when it came time to start looking at medical schools, I knew that you could, the military had a program where they would pay for your school, and then you would owe them a certain amount of years of service after you got done with school. And that program was called the Health Profession Scholarship Program. Yep. So I went to the recruiter, and at that time I was in pretty good shape. I was working out all the time, playing basketball, playing baseball. And I went into the recruiting station. And of course, most Navy recruiters work side by side with a Marine Corps recruiter. They're typically in the same building. And I'll never forget, I walked in there and the Navy recruiter was out, and there was a Marine Corps recruiter, and he had been a DI in the past. And this guy was like, he looked like a Marine, right? He's probably 6'2", 210 pounds of solid muscle with a 28-inch waist, 44-inch chest. Yeah. His big uniform just looked perfect. Big guy, booming personality. And he goes, what do you want to do? And I said, well, and I didn't know anything. I said, sir, I'm looking to join the Navy because I want to go to medical school. He goes, why don't you join the Marine Corps? And I said, well, sir, I'm actually, I have my degree and everything, and I took my MCAT. And he looked at my papers and everything. He goes, man. He goes, damn. He goes, okay, doc. He says, well, listen. He goes, we swear too much to have chaplains, and we're not smart enough to have doctors, so we get those guys from the Navy. So I'll set you up. You're good. And I was like, okay. So that was my first experience between the Navy and the Marine Corps and everything. So I applied for what's called the Health Profession Scholarship Program. And when I got accepted into medical school, the Navy was nice enough and gracious enough to give me that scholarship. So they paid for my school while I was in medical school, and then they gave me a stipend to live off of. So then when I graduated from medical school, which was in 2007, I went active duty. And so my first duty station in active duty was as a general internal medicine intern at a place called the Naval Medical Center in Portsmouth, Virginia. Yeah. And at that point in time, I thought I was dead set on wanting to do pulmonary critical care or maybe even nephrology. My uncle is an intensivist, a critical care doctor, and my father is a kidney doctor, a nephrologist. And so my understanding of internal medicine and doing that training was what they went through in the 70s as house officers at St. Louis University. And in those days, there was no ER doctor, and the residents, where we get the term resident from is you were a resident of the hospital. Yep. So I can remember being a little guy and just being, if I saw my dad, it was like a treat because he was always at the hospital when I was younger. So that was
How
my
many hours a
understanding.
day
Yeah.
would you spend there actually? Like,
Well, when I was when my dad was in training, there was no limitation. In fact, I remember him telling me that his program director at St. Louis U would brag about how many divorces he was going to cause, and you'd be Q2, meaning you'd be on call every other day. And he apologized to them for all the pathology they were going to miss when they were at home sleeping. So that was kind of the old school way of being, of your training. And I mean, there's story after story talking to some of the guys that came before me as far as how they would do their training. So anyway, I got into my internship and things had changed pretty dramatically. And I love internal medicine doctors. They're the smartest guys on the planet, but it just wasn't for me. And I was in my third month, and I'm hanging out in the ICU. I'm doing my ICU rotation, so my critical care rotation. And I noticed that one of the senior anesthesia residents, who was my resident, all of the nurses and staff would go to him when they needed a line or they needed an airway or they needed some action. There was some action. He was the guy that was running to the fire. And his name was Steve Blackwell. I'll never forget him. He's a great guy. And I looked around, I said, I want to be like that guy. And so we started talking, and he says, hey, if you're really interested in critical care, if you do anesthesia, it's almost like doing a critical care residency. A lot of people don't understand a lot about anesthesia, but first of all, 15 of the original 25 guys that established the Society of Critical Care Medicine in the United States were anesthesiologists, number one. And then number two, when you put someone to sleep, what you're doing is you're creating conditions for the surgeon to be able to operate, but you're altering that patient's anatomy and physiology. And so now you have to be an expert in the ability to effectively deliver oxygen to that patient. So it's pure physiology. That's what you're dealing with on a daily basis. And it's basically pure critical care. When I would teach my residents, I would say, hey, you're doing a critical care residency. That's how you have to think about things. So it's acid-based,
very real time, right?
Fluid electrolytes. Yeah. Everything's quick. That's a little bit of a difference between the OR and the ICU, is that a lot of the things that you're doing are similar. It's just things happen very rapidly in the OR, and sometimes they don't happen as rapidly. Although the ICU can be a pretty rapid, fast-paced environment when you got somebody that's sick. But for the most part, you're moving through things very quickly in the OR. And so within that day, I started talking to Steve Blackwell, and we started talking, and within 30 minutes, I was like pretty much 90% convinced I wanted to be an anesthesiologist. And then I went home and talked to my wife about it, and of course, she's also a physician and very intelligent, and she, we made the decision together. So within 24 hours, I was changing my course. So the way that works in the Navy is that if you want to do something competitive like anesthesia or ER, typically you got to go out with a fleet, and there's typically 4 different options that you have as what's called a medical officer. So you can go be a dive medicine officer. We call that a UMO.
Okay.
You can go and be a flight surgeon. You can go on a ship and be a medical officer aboard ship, or you can go with the Marines. And so I really joined the military because I wanted to be with the Marine Corps. My grandfather was an infantry Marine in the South Pacific, and I was always really close with him. And so I just decided at that point that I would just raise my hand. And of course, nobody wants to go with the Marines, and so it's easy, especially as a guy. That's a no-brainer. So I went for a year out to Okinawa, and I was with a 3rd Marine Logistics Group in Okinawa, and spent a year out there unaccompanied as what's called a general medical officer. And then after that, I came back and finished my residency. So I did a residency, 3-year residency in anesthesia, and that was from 2009 to 2012. And then from 2012 to 2015, I stayed on as an attending where I had trained, and that was at the Naval Medical Center, Portsmouth. That was interrupted by close to a year in terms of the workup, the deployment, and then the debrief. And that was with that was 2014, so we call it 14 TAC 1, first part of 14. And that was with 1st Med Battalion. in service of, with underneath 1st Marine Expeditionary Force, in service of 1st Marine Battalion, 7th Marine Regiment out of Camp Dwyer in Afghanistan. And so we had our company was split up into, some of the guys stayed back at Camp Bastion, call that Leatherneck.
Yep.
And then some of the guys in our company got to go down to Dwyer. And the guys at Bastion really didn't get to do a whole lot at all. At Dwyer, we weren't super busy, but we had a couple, we did some trauma, and I think we did pretty well as a team. It was just one of those things where we went, it wasn't the sexiest deployment, but we stood our post. We were ready for whatever came at us. And then for the most part, our guys were staying safe. And it's not like, as a medical guy, you're not sitting there saying, man, I hope I need some action. No, you're kind of like,
I'm sure you saw plenty of it. I mean,
you saw a little bit of
some of the
action,
things you
but-
must have seen in a shock trauma platoon had to be somewhat traumatic. I know that
Well-
I know you go through a lot of training as a doctor to be able to, handle and deal with some of those things.
What's interesting is that I literally looked at it as I think, and we just got done talking with Trey. Obviously, he's deployed multiple times. I think the best way to when you do any kind of deployment, the best way to do a deployment is you have to, and I remember thinking this, the guys that struggled or the guys that couldn't get through this, is you have to set yourself aside. So you can't, you're not any, you have to just understand, my family's back at home and my wife might be going through something, or my kids, or, Felicia and I have some really funny stories about that. Actually, it wasn't funny at the time. Now we look back and we laugh, but you have to kind of separate yourself from all that, and you have to forget yourself, and you have to say, okay, I'm here. I got a job to do, and I just need to do it. And there's
Complete
just
mission,
no other
right?
way to do
Every day.
There's no other way to do it. Yeah. And we weren't busy. I mean, we were not, it was, like I said, it wasn't the sexiest deployment. We were ready for whatever came at us. When we did get stuff, we did well. And for the most part, you sit back and you say, okay, our guys are staying safe. And it's not like if you get a trauma, you're like, damn, I want some more traumas. I wish we had 5, it's like, no, that's, you're not saying that or thinking that or any of those kinds of things. But I will say, when you deploy, your family deploys with you. And, the funny thing is that it's a funny story. Trey is going to laugh at this story, but I can remember there's a trauma surgeon that worked with me. His name is Tim Plotz. Absolutely great dude. We're buddies to this day. He's an Iowa guy. He still lives in Southeast Virginia. He's a captain at this point. He's an 06, surgical oncologist, and he is he's a program director of surgery, general surgery at the Naval Medical Center Portsmouth. And we're hanging out every day at Pendleton, right? So we're getting ready to deploy, and we were like thick as thieves. Every day he and I are hanging out. And so on our orders, it said on our orders that you get $80 a day for your per diem, right? And so we're going through this, and we're going out in Southern California is not a cheap place, so we're spending money. We know we're deploying, and so maybe we're having a beer or two every night. Maybe more than that sometimes, and we're getting ready to deploy, and we know it's going to be, and so it says $75 a day. So fast forward 2 months, I'm in Helmand Province. It's February. And Felice calls, we talk, and she says, the dog's sick, the heater broke, the washing machine broke, right? So all these things going on, life hits you. And then I see she says, when are we going to get reimbursed for all that money you spent? It's not like you're wealthy when you're in the military. I said, I kept saying, it'll come. And then that day I found out that on like page 7 of my orders, it said, if you actually live on base, your per diem's like $12 a day, as opposed to. So
you're out there spending.
So I had to
beers.
I had to pick my spot to figure out diplomatically when I needed to kind of throw that in there with all the other things that were going on. And I think my son was acting out in school, so there was all kinds of stuff, But that's the thing, is they deploy with you when you do it. Right. So when we do Hooks of Hope, that's one of the things, is we're looking at not just helping God work through the lives of the veterans that we're working with, but healing families.
Absolutely.
And really talking to families about how do we get this how do we allow God to work in your family? You know?
Yeah, I mean, I definitely learned that. Like one of the things that prompted the development of Hooks of Hope, and really our core mission is to bring hope, right? It's to heal, encourage, and restore people. But when my testicular cancer journey, really opened my eyes of how powerful hope is, especially when you're dealing with, potentially hopeless or really dark type situations where you could be fighting again, it could be you're fighting disease or you're fighting some sort of something of great difficulty. Hope empowers you. Hope builds you up. It gives you strength to fight through adversity. So that's really what we're aiming to do here.
That's
helping people through, whether it be through fishing, through mentorship programs, through financial assistance. We want to provide clinical counseling to those who need it, as well as regenerative medical care.
That's it.
So, speaking of regenerative medical, how'd you get into the regenerative medicine side? I'm, my background a little bit. I was very much into sports medicine and physiology and that kind of stuff and biochemistry and all that. But was it your athletic career that kind of led to that?
It's a total God story, and like all things, so rewind a little bit. So it's 2014. I get back from Afghanistan, and I'm not a super. Just the way it works in the Navy is doctors are sort of similar to pilots in that if you want to make rank, the more and more you sit behind a desk and you're not doing it. And I had zero interest in doing any of that or being administrative or sitting in meetings and this kind of thing. And so I said to my department chair when I got back, great guy. His name's Mark Leonard, Naval Academy guy, sharp guy, super smart guy. I said, listen, Mark, I said, dude, I'd rather just not even check email for the next year. I'm getting out. I got zero desires. I got zero desire to sit behind a desk. That's just me. I'm not saying it's bad. I just don't want to sit behind. I don't want to check email. So I said, give me the biggest, baddest cases that you have. I'll do anything you want me to do from a case standpoint. And I'm there. I'm a gamer. I like being in that battle arena. I said, give me these big cases like this, the ones that people don't want to do. And but I said I don't want to. I'm just going to be an 04. I'm going to get out and punch out in 15. It's just, and at the time also I wanted to do a fellowship in either critical care or cardiac anesthesia, and nothing was being approved just because we were super fat. So this is no problem. So from 14 to 15, I did a lot. I started really kind of diving into what we call transesophageal echo. I was doing thoracic cases. I was doing a ton of oncology cases with plots. Yep. He's a same kind of mentality, likes the big cases, likes to do the retroperitoneal sarcomas and the Whipples and all this kind of thing. And so we were doing a lot of those cases. I got out in 15, and at that point in time, I was pretty close to being boarded in what we call basic perioperative transesophageal echo. And that's where you put basically a probe into the esophagus, and it sits behind the heart, and you get real-time ultrasound images of the heart, and so you can figure out. It's a useful tool for the OR. It's a useful tool for the ICU because you can figure out very
what's
quickly
actually going on.
Yeah, exactly. Why someone's unstable, and you can make these quick adjustments. And so because I was close to being boarded in that, I thought, hey, I'll just do a critical care fellowship, and then I'll have dual, basically. Not be fellowship trained in both, but have knowledge of both. So I go down to Jackson, and I started a fellowship down at Jackson in Miami. It's where my wife's from, and I get into that. And the bottom line is that I just felt like I was a little bit out of place. I'd been an attending for 3 years. I'd been deployed. I was close to being boarded in critical care, and a lot of the guys that I was with were just younger. And, they were just kind of, I was close to 40. A lot of these guys were late 20s. They had not been military. Miami is a great town, but not exactly a super military town kind of a deal. And so I just my wife was pretty miserable with her job. So I started looking around a couple months into the fellowship, and I discovered Vero Beach and discovered that they had a small small private group, which is sort of a relic of the past at the time in Florida. And so I joined what's called Anesthesia of Indian River. And then eventually, as being part of that group, I joined the cardiac team. There's about 20 docs, 20 physicians, and there were 2 cardiac anesthesiologists. And they asked me to be the third guy. And so I had my basic perioperative TEE board. But in order to be, I didn't have to do this, but just because both of the other guys had already passed it, I challenged the board for what's called the advanced perioperative transesophageal echo. And when I did that, I knew I couldn't get boarded in it because I had done my residency. So a lot of the old guys could get grandfathered in, but I'd done my residency after a certain point in time. So what it just meant is I'd become a testemer. So I took the test for the advanced perioperative transesophageal echo and passed it, and that test was an absolute ball buster. So this is fast forward. I'm basically doing a lot of thoracic, a lot of cardiac. I work a lot with the vascular surgeon, and essentially what we're doing is we're intervening at end-stage disease, and we are attempting to solve this problem. For instance, with we'll use a coronary artery bypass graft as an example. They've got essentially these plaques in their heart that are blocking blood flow, and so you're harvesting various grafts throughout the body and trying to bypass these obstructions, and you're essentially putting a Band-Aid on a problem that is a systemic problem. Not to say that it's not necessary or not needed, but I started to think about it in terms of why aren't we trying to more effectively understand the disease process and then potentially intervening in this disease process way earlier. In other words, focus on prevention as opposed to waiting for people to get sick and then intervening at end stage and then allowing someone like myself to fly through the asteroid field, guide them on to what we call cardiopulmonary bypass, the heart-lung machine, come off of that machine, and then go to the ICU. Why aren't we really doing a better job of trying to understand the way that vascular disease develops? And so this led me into this whole thing. And so my wife had been a functional medicine doctor for a handful of years, and I had kind of was fluent in the language, but hadn't really devoted myself to doing it full time or becoming boarded in it, or really spending all of my effort and time perfecting this craft. And so what happened about a little over a year ago, is I was out playing basketball for the first time in years. And I was playing with a friend of mine, and I basically said, "Hey, Lord, I want to take my relationship with you to the next level, and I want to, these guys are great guys that I'm having fellowship with." And I go out there and I'm playing basketball. I was having a blast. I actually felt pretty good. My win was actually decent. I hadn't played in years, and I get about almost done with the first game, and I go to try to cross this guy over, 45-year-old white guy with a gray beard, trying to cross a guy over, right? And I slashed my patella tendon, just slashed it. And my knee starts to swell up, and I'm looking, and I'm getting wheeled off the court, and I'm looking up at God like, okay, I guess this is an answer. I guess this is an answer to your prayer.
You broke my knee,
I'm assuming, yeah, whatever, And what's crazy is that for the next 2 weeks, I got operated on quickly. For the next 2 weeks, I had nothing to do. I literally had to sit in the house, and for me, that's torture. So Felice has all these books laying around the house, and in like a week, I read Peter Attia's Outlive. I read Avram Blooming wrote Estrogen Matters. Richard Johnson wrote Nature Wants Us to Be Fat. Let's see.
Testosterone for Life.
Testosterone for Life. Abraham Morgan Taylor. And then Nir Barzilay wrote Age Later.
Yeah.
And so it was like the light bulb went off. And I said, you know what? I don't think I'm ever going to permanently leave the OR, but I said, this is really interesting. And so
it's amazing when all those kind of puzzle pieces come together and you see the picture.
Right. So I noticed one of the things is that I really started to try to do a deep dive into trying to understand what we call insulin resistance.
Yep.
And there's a lot of hubbub around it, but really it's to simplify the way that we think about it, it's just the cells and then by extension the organs in the body. It's an inappropriate response to the effects of insulin.
Yeah.
And so the reason why this is something that we should actually measure and target is that if we can, insulin resistance is upstream from not just type 2 diabetes. That's typically how most people understand it, but it's upstream from Alzheimer's, dementia. It's upstream from coronary artery disease. It's upstream from peripheral vascular disease. It's upstream from stroke. It's upstream from kidney disease. It's upstream from fatty liver, sexual dysfunction, endothelial cell dysfunction, and the list goes on and on.
The byproduct of a lot of those end-stage diseases too can be depression, anxiety, right? You're having issues with stress, elevated cortisol levels. I mean, these are things that, you know, a lot of people in our society on an everyday basis are experiencing, especially in the veteran community. Right?
I'll take it even a step further. The way that insulin resistance is a big driver of depression and anxiety right now. Right now. And it's also one of the ways, I'm not sure if it's completely elucidated as far as why is it that insulin resistance leads to Alzheimer's disease. But if you think about Alzheimer's disease, to try to make it simple, you have basically what's called dark matter, and then you have white matter in the brain. The white matter are kind of like fiber optic cables, and then dark matter a lot of times are composed of these cells that we call neurons, right? And so one of the sine qua non, or the essence of Alzheimer's disease, is you get what are called tau proteins in neurons that alter the function of the neuron. They make the neuron not work. And then you get deposition of what are called beta amyloid plaques in the white matter. What's interesting about insulin is when your body is insulin sensitive, what happens is that there's a receptor at what's called the blood-brain barrier that upregulates when it's highly, highly sensitive to insulin, and that insulin moves into the brain, and it's effective at removing these beta amyloid plaques and preventing the phosphorylation of that tau protein in the neuron. So maintaining metabolic health.
So that phosphorylation degrades the
that's
neuron?
what causes the deposition of that tau protein in the neuron. And so preventing that phosphorylation somehow, and I might be messing up the mechanism of action somehow, but somehow you don't get those tau proteins in the neuron. So the point is by maintaining metabolic health, that's one of the ways that we prevent or perhaps even offset the development of Alzheimer's disease. And there's a lot of, for instance, 50% of everybody that gets diagnosed with type 2 diabetes already has coronary artery disease, meaning they have plaques in their coronary. So instead of waiting for someone's hemoglobin A1C to rise and then saying, oh, you're pre-diabetic or you're diabetic, why don't we actually measure and target the insulin resistance and try to develop strategies to reverse it? And so in so doing, you're going to start preventing disease, but you're also going to make the patient much more functional now. So this is what we should be doing as doctors, is I should be helping people be much more functional at whatever they do. If I'm treating a police officer, I got a patient right now, you know, he's probably 60 pounds overweight. He's got metabolic syndrome. You know, I've got police officers, firemen that are like this. So I'm like, okay, you're a professional athlete. Last time I checked, your job is not safe. Your job is dangerous. My job is to make you functional right now. And then the goal is, if we're preventing and we're functional now, the goal is in the long term, you're going to live longer, but not just live longer, your health span is going to be improved. So that's the years of life that you have where you don't have chronic disease. So you and I, if we do, you know, now there's no guarantee, but if we do everything the right way, we should have this same conversation when we're 80. You know?
So, you know, insulin's part of, like, in our veteran community. I want to talk a bit about, you know, how insulin resistance and or metabolic syndrome plays into that community, especially with either active duty or veterans who may be dealing with post-traumatic stress disorder, or, you know, various disorders that, you know, can come out of the being involved in a traumatic event, but also other hormones where you have hormone dysregulation, whether it be testosterone or cortisol, those types of things, and how those play into PTSD. So, you know, to kind of bring that in, I guess, in dealing with the veteran community, because I know you treat a lot of vets for PTSD and other things, right? What are some key things there that you typically see?
Well, let me say this. The first thing I think that we should understand about patients in general and the veteran community specifically is that every organ system affects other organ systems. So if my gut health isn't on point, then my gut health is going to affect my metabolic health. If I'm not metabolically healthy, that's going to affect my cardiovascular health. If my cardiovascular and gut health and metabolic health isn't where it needs to be, that's going to affect my brain health. So that's number one. The second thing is that a lot of if you look at the strict definitions of PTSD and traumatic brain injury, PTSD is said to be caused by an emotional event. So not necessarily a trauma, a physical trauma, but an emotional trauma, whereas traumatic brain injury is typically caused by a physical trauma. But if you look at the pathophysiology within the brain, it's oftentimes very similar, and it's basically related to oxidative damage, inflammation, and then like this sort of excessive excitatory problem that occurs in the brain. And so downstream from that, a lot of times veterans are, low testosterone. Cortisol, if it's heightened constantly, there's a whole process where you have what's called a cortisol DHEA pregnenolone curve. Yep. And typically what I see in my business owners who are 45, 50, guys like you and I, is that our cortisol is really high, and then maybe our DHEA is really low. And this is sort of the beginning of
You've demonstrated that to me in blood work.
Right.
Yeah.
Correct. Yeah. And that can be deleterious. A lot of times with your PTSD guys and your guys that have had multiple deployments, they're way to the right on the spectrum. So what happens is their cortisol, their DHEA, and their pregnenolone are all low. What that tells me is that cortisol has been hitting the brain constantly, and it's just been destroying and frying the brain. And so one of the effects of that is they may not have the capacity to make what's called luteinizing hormone or follicle stimulating hormone. Those are two hormones that are released by what's called the anterior pituitary. Yep. They go to the testicles. The luteinizing hormone tells the Leydig cells in the testicle to make testosterone. Yep. The follicle stimulating hormones tells the Sertoli cell to make sperm. Coincidentally, one of the things fertility specialists will tell couples when they've done tests is they'll say, hey, go on vacation. Forget about everything, go on vacation. In other words, stop stressing. Get the cortisol level down, stop stressing, and lo and behold, they go on vacation, there's no kids, we're pregnant, right? So the point is that we should be looking at testosterone. We should be looking at thyroid. Thyroid stimulating hormone is released from the anterior pituitary. We should be seeking to optimize the thyroid. There's a correlation between, at least in the long term, the development of insulin resistance and metabolic syndrome in our veterans. We should be looking at that. And related to that, there is also a relationship between PTSD and coronary artery disease, because these patients are predisposed to metabolic syndrome and insulin resistance, among other things, and the stress and all these things. So these are things that we should be doing a deep dive. We should be looking at their cholesterol panels, but also what we call an advanced cardio IQ cholesterol panel. We should be doing full hormone panels. So testosterone's a three-dimensional game. So
right.
But we should be looking
Walk
at that.
Through that real quick.
Yeah, let's do that. So there's a lot of hubbub. I mean, there's obviously testosterone clinics going up everywhere. And there's a lot of, so we just give the testosterone. Sometimes it's overdosed, and then, so that's it. The reality is that we are walking around in our society with testosterone levels and sperm counts that are way lower than our grandfathers and great-grandfathers. Nobody really knows why, okay? Is it because, we're sitting at computers and not building the Empire State Building? Is it because we're the crap in our diet? Is it because we have ubiquitous metabolic syndrome? So guys are walking around with extra abdominal fat, and that fat will convert the testosterone into estrogen. Nobody really knows why. Is it a combination of all three? Maybe. But the point is, we are walking around with low testosterone. If someone's testosterone is low, most of your good data dealing with testosterone, I should say a lot of your good data dealing with testosterone, when you bring it into a youthful range, deals in the realm of improving metabolic health. So in other words,
as well as emotional health.
Well, all of it. But let me just address the fasting glucose, the fasting insulin, the A1C, all of those parameters in the setting of metabolic syndrome and or diabetes get better in the setting of testosterone replacement therapy. The second thing is abdominal fat decreases and it becomes less inflamed. I think one of the big drivers of systemic insulin resistance is this inflamed adipocytes, these fat cells around your abdomen, and they become resistant to the effects of insulin, and that sets off an entire cascade that is pathophysiologic throughout the body. So addressing that, and then you're exactly right. The secondary effects of that are improved emotional health, mood gets better, energy gets better,
Right.
sleep gets better. And so testosterone in and of itself, bioidentical testosterone, is not the only way to replace testosterone. You can do, there's nutritional supplements. A lot of times, just by cleaning up the diet and reversing the metabolic syndrome, your testosterone will start to rise. You
Limiting
lose weight.
or limiting or eliminating alcohol.
Number
consumption
one,
too.
high fructose
Yep.
corn syrup,
Yep.
improving sleep. So decreasing the cortisol levels, resistance training. So these are just some natural ways, different nutritional supplements. But then once you start getting into the replacement, things like, the first question you should ask, especially a man who's maybe 40 or 42 or whatever, is, are you done having kids, right? If they're low and they seem like they don't have any contraindications and they seem to be a candidate, are you done having kids? And if the answer is no, well, then there are treatments that you can use that are going to maintain fertility, things like clomiphene or HCG. And then once you've made the decision to replace the testosterone, you've established that there aren't any contraindications. You have to understand that when you replace it, the testosterone that you're giving can convert into different things that can potentially be deleterious. Things like extra estradiol, estrogen, things like dihydrotestosterone, where if that gets too high, you can lose your hair. You need to check the prostate-specific antigen. We call that the PSA. Check the hemoglobin and hematocrit. You can get a secondary elevation in the hemoglobin and hematocrit. If you have undiagnosed obstructive sleep apnea, that's going to be a contraindication. So it's really a three-dimensional game, and you really have to understand the patient. You have to understand your history and your physical, what their desires are, their lifestyle. And then it's the art of treatment, So, but I think that just looking at that.
What do you think some of the drivers are, particularly within the veteran community and the active duty community? Probably more in the veteran community, but when they get back from Afghanistan, from Iraq, wherever they were stationed, it's a common thing for you to see a pretty significant reduction in testosterone with a lot of these guys.
Absolutely. I would, is this related to just this constant lifestyle of if you look at our special operations community, especially the government, it's a tool that we've used for a variety of different reasons. It's a tool that we've used over and over and over and over again to do a lot of work, and then we use that tool until it breaks, right? And then they come back, and oftentimes physicians and and I include myself in this, we're all coming up short. We're not taking that integrative approach and doing that deep dive to really get to the bottom of what's going on. And is it the rampant, is it the traumatic brain injury? Is it, all of the inflammation? Is it, some guys, unfortunately get involved in drugs and alcohol and some of these kinds of things. So I think the other thing, and this is why I love this charity, is this is not just a medical solution. We are, that's my job, is to focus on the medical aspect of things. But really what we want to do is we want to allow God to work in the veteran's life, to do things, to get him or her around other veterans who have gone through the same types of experiences, so they're not isolated, to develop those lifestyle habits that lead to productivity, that lead to renewal, rebirth for that second half of life. So from the age of 40 to 80, we need to really actually start thinking about these things, and we need to start, unfortunately,
wellness, right? Like holistic wellness.
How do you, 1,000,000%,
the mind's not going to be well if the body isn't.
I think, I'm a civilian now, but I think one of the problems that I see with the civilian sector is that we oftentimes sit down with patients, and I'm not blaming any one entity or institution or whatever, but because of the circumstances that we're in, oftentimes it's a 10-minute visit. There's a lot of paying attention to the computer. Yep. And then there's what I now have to do is convert this interaction into computer-generated platform that I can send to the insurance company so that I can get paid. And what becomes secondary is, am I actually improving the health of the patient?
Right.
So
figure. Right?
yeah. So
Yeah.
so like for instance, just like little things like there's an integrative cardiologist. As I sought my board certification with the functional medicine
Right.
piece, there's an integrative cardiologist by the name of Mark Houston, and I've gone to hours and hours of his lectures, and the guy is he's brilliant. But it's like, there's little things. When someone's blood pressure is high, there's this sort of Pavlovian, we throw, we'll just say, okay, the first line treatment's hydrochlorothiazide.
Second line beta blockers.
The problem with hydrochlorothiazide is that it actually can exacerbate insulin resistance. It can actually cause dyslipidemia, and those kinds of things. So I'm not saying the hydrochlorothiazide is a contraindication, but why don't we seek to understand why the patient's blood pressure is high? Let's see if they start losing weight.
Yeah.
Let's see what's their magnesium level, what is their renin level, what is their aldosterone level, and if you still don't have it figured out, well, you can start looking at their genetics.
Yep.
And there's a whole genetic panel, like where you can look at multiple different things that the patient might be predisposed to from a genetic standpoint. So
speaking of genetics, I've never done any research on this in particular with some of the, there's a lot of new science out there. Well, I say new, but it's been around for a while, but there's a lot, I guess, of buzz around genetic mutations, things like MTHFR.
Oh yeah, you brought up a great point.
Patients' abilities to process things like folic acid and folate.
So there's two different mutations there's probably more, but the two big ones are the 677 mutation and the 1298. The 677 is more clinically relevant. It started getting a little bit more notoriety, if you will, when Dana White came out with the UFC, and I think he went down to a lab in Miami, and he was found to be, I believe, homozygous, meaning he had both genes for the mutation for the 677 mutation. So what does this all mean? MTHFR. Well, this is a mutation to an enzyme that allows your body to methylate B vitamins. So translate that. So methylate means it just adds a molecule that has a carbon and 3 hydrogens to the B vitamin.
Yep.
Why is that important? Well, the first step when you ingest a B vitamin is your body methylates that B vitamin, and then the next step is it converts that methylated B vitamin into things like taurine, into things like tyrosine, things like tryptophan, dopamine. So if you have
super important.
Yeah. If you have a mutation to that enzyme and you can't effectively methylate those B vitamins, well, then you might be predisposed to things like high blood pressure, insulin resistance, weight gain, depression, anxiety, low
Headaches.
Thyroid, addiction.
Yeah.
If you can't effectively make dopamine because you can't make tyrosine, well, then when you get your first dopamine hit because you got a buzz or whatever from alcohol, you now might now be predisposed to alcohol dependence. And so the treatment. Go ahead.
Go ahead on the treatment.
Yeah. Well, the treatment's easy. So we do that test in our clinic. And if you're heterozygous or you're homozygous for either one of those, you just put the patient on methylated B vitamins, and a lot of the problems tend to get better.
Which can be bought on Amazon or any local
over the counter.
Yeah, over the counter.
And that gets into like for instance,
they're relatively inexpensive, but those really are that's something that you can see manifest in a lot of people's lives, and sometimes the fix is a lot easier than they think.
Yeah.
So Brett, we've covered a lot of ground on metabolic processes, on hormones, on all sorts of different issues, that people can run into, MTHFR, et cetera. One of the things we commonly see in our veteran population are serious orthopedic injuries, whether it's from battle or whatever. But a common issue that we see is somebody will have an orthopedic injury that leads to medication, right? Which then down the line, they're mixing that with alcohol. It leads to addiction, and then kind of the
spirals out of control.
Right, it spirals out of control.
Yeah,
so, what are some alternatives to?
Yeah. Well, I think the first thing that we should think about is we need to understand that all these processes are related, and they're related to inflammation. I preface what I say with, I'm not an orthopedic surgeon. If someone has an injury, the first question that I always ask is, do you have imaging, and have you seen an orthopedic surgeon? And is this something that is it a mechanical issue to the point where it requires surgical correction? And that's something that I defer to my orthopedic colleagues. But beyond that, generally speaking, as an anesthesiologist, first and foremost, opioids in the perioperative setting, meaning in the acute perioperative setting, are fine. After that, generally speaking, there's a couple indications in the clinical setting for opioids in the chronic pain setting, but those are few and far between. So generally speaking, I hate opioids, okay? What we should be focusing on is functionality and then reducing the levels of inflammation. So couple things. Number one, there are new types of therapies called peptides. They're actually not new. For instance, vasopressin in the body is a peptide. Insulin in the body is a peptide. What does that mean? Well, the definition of a peptide is different in different countries, but generally it has to do with, I think in the United States, it's 50 or more amino acids in sequence is a peptide, I want to say, and that peptide moves to the outside of the cell and then tells the cell to do something to carry out a specific function. So, for instance, with regard to orthopedic injuries, there's a couple of things that come to the top of my mind. One thing is called ipamorelin CJC 1295. It's CJC 1295 and ipamorelin. And what ipamorelin does is it moves to the outside of the cell and it tells the cell to make growth hormone, but the cell will make growth hormone and release it in a natural way. So you're not going to it's not like giving yourself growth hormone where you take it in an unnatural way. In other words, you have the exact same.
It's a secretagogue.
Secretagogue, right.
Yeah.
Well, and you release it in the exact same way that your body's going to release it normally. So you get a diurnal pattern where you'll release some in the morning, release some at night. The other thing that I can think of right off the top of my head as far as a peptide is something called what we call BPC 157, and that is something that was isolated from gastrointestinal juices, and what it does is it's thought to improve. It's an anti-inflammatory. It increases anti-inflammatory cells. It decreases pro-inflammatory cells. It tightens the junctions of the intestinal cells, so you get less intestinal permeability. The thinking is with that you get less arthritis. I've put a lot of my athletic patients here in the Vero area on BPC 157, tennis players, golfers, and they love it. Weightlifters, CrossFit guys, some of these weekend warriors, and they absolutely love it. And I have a couple patients who didn't even tell me that they may have had something like inflammatory bowel disease or irritable bowel syndrome or whatever, and their symptoms a lot of times start, get better. So that's a second thing. So just peptide therapy in general is a field that's really exploding. And then the other thing is stem cell therapy. So as a general rule, you can get stem cells from bone marrow, you can get stem cells from fat, you can get stem cells from your vessels, from your blood vessels. But generally speaking, what you can actually do with people is you can harvest, in the case of, for instance, fat or bone marrow, you can harvest stem cells. You can remove the fat. Okay, so say we're doing what we call adipose-derived stem cell. You can remove the fat, and then you're left with basically what's a mesenchymal stem cell pellet. And then what you can do is you can combine that with something called platelet-rich plasma. Platelet-rich plasma is just, the way you obtain that is you pull off a sample of venous blood, you spin the blood down, you take the red cells and the white cells away, and you're left with platelets and then plasma. And then you combine that with the stem cell, and you can inject it into an area that you've got inflammation. Why
does that do?
Yeah, PRP. So we've known for 2,000 years that that blood clots. With the advent of the electron microscope, we can look at an area of trauma And we can see that when you have a tissue trauma and the tissue starts to bleed, that when you get this coagulation cascade, meaning the platelets and the clotting factors moving into the area, not only do they stop the bleeding, but they also attract all these cells to move into the area and start regenerating the damaged tissue. So you can actually pull venous blood off of a patient, remove the white cells, remove the red cells. You're left with platelet-rich plasma. You combine that with the mesenchymal stem cell, you inject it into an area, and that PRP, that platelet-rich plasma, will perform the same functions. And so the other exciting
Literally
thing,
allowing you to heal yourself.
exactly,
Right?
it's a regenerative therapy.
Yeah.
And then, the other exciting thing is that,
And that's basically the natural process. You're just accelerating and or amplifying that natural process.
exactly.
Right?
The other
Put more
part
troops
of
on the ground.
What's
right?
that?
Put more troops on the ground.
You got it. Yeah,
Right.
it's and the best way to a nice way to understand stem cells, like say for instance you've got knee osteoarthritis. When you inject stem cells into the knee, those stem cells are now engaging in that ground and pound campaign against the inflammatory cells. But what those stem cells also do is they call in air. So they call in all these other anti-inflammatory and regenerative mediators to overwhelm that pro-inflammatory component, with the hope that you start getting improvements not just in your inflammation, but also your pain and your functionality, which is the whole goal.
Yeah.
The other thing that's really interesting is that I know Mexico, Panama, some of these other countries have started to get, you can actually culture expand your own stem cells. So that's something that in the United States isn't quite yet available, but hopefully in the near future, we'll be able to actually, add growth factor to the harvested stem cells and then turn millions of cells into hundreds of millions of cells. So your regenerative yield is just that much more robust.
Very cool.
So
Welcome to the future.
yeah, well, and it's
just
not
cool
just,
stuff.
I want to make this point too, is I'm kind of more interested in trying to understand its effects with things like traumatic brain injury, the
Yeah.
inflammatory component of what goes on with PTSD and TBI, and even you get what are called endothelial progenitor cells, and that potentially can be a treatment for vascular disease. So
Yeah.
minimizing the vascular immune dysfunction that goes on with the development of atherosclerotic plaque.
Yeah.
So these are all potential things that we can
Amazing
explore in the
stuff.
future. Exactly.
We're going to live to like 150 one day.
That'd be nice. That'd be nice,
So, man, you and I, we're friends. We fish all the time together. We fish inshore, we fish offshore. We run to the Bahamas and back. We spearfish. We do all kinds of stuff. So, what prompted you to want to get involved with hooks?
Yeah. So Fred Galvin called me, was about 2 months ago.
Yeah.
And I know you had met Fred. It was about a year and a half ago. It was you and I, George Izinga, GT Paris, Matt Paris. And I said, hey, Fred's coming over. And all these guys, these are all local guys, all our
We're all
age
buddies.
and whatnot,
Yep.
all our buddies. And they wanted to sit and hear Fred, right? So he came over and we're all sitting around and doing our thing and grilling and everything. So Fred called me 2 months ago and he said, hey,
It's actually, I think it's been about 6 months now.
yeah. Oh, is that how long
Yeah,
ago?
yeah.
So he said, whatever, my brain, maybe I need some stem cell, but
BPC 157 to the
some
brain.
kind of thing for my brain. But so he said, hey, this happened. And so I felt like a guy up on a mountaintop, like, hey, he says, it's the fourth raider that I've heard about in the last 2 months who's committed suicide. And I said, Fred, I think I have some answers. I can help.
Yeah.
And I'll take it a step further. There's always meaning in life for everything. And, as a kid, my grandfather was super influential in my life. I'm not a trust fund baby. I didn't receive a trust fund from my grandfather, but what I did receive is just a way of being and an eternal gratitude for an appreciation for the military. And, he was a Marine in the South Pacific. He's the reason I joined the military. And I'm looking at this like, if we don't do something about this, if we don't at least get down and get into the nitty gritty and start working at this and start asking God to allow us to work in other people's lives, then I don't think I'd be able to live with myself.
Yeah,
so it's like, let's make sure it's Christ-centered, but let's get involved in this. Let's do the fellowship. Let's listen to these guys. Let's love on these guys. Let's do the weekend of fishing, but then let's have some teeth behind what we're doing. Let's see if we can get them plugged in with the functional medicine docs or the regenerative medicine docs that are going to kind of look at a lot of these different problems. Let's get them involved in counseling with other guys that are combat veterans. Let's get them in good churches so that these guys can have experiences similar to our brother Trey and also Fred Galvin. And so for me, it's personal. It's like this shouldn't be happening like this.
It's unacceptable, really.
It's unacceptable.
Yeah.
You and I, we live this incredible life. We get to, experience all these things that the United States has to offer because these guys were willing to go through things like this.
Yeah.
And so I think this transcends politics. It really, we're faith-based, we're Christ-centered, but it doesn't matter, every American should view things like this. If you haven't served, you should at least have an understanding and have an appreciation for those who have served. And I'm not just talking about the guys who have served. I'm talking about the guys who have been in combat.
Yep.
And so, this is, God's going to grow this, and that's why I'm involved. And I just encourage everybody who's listening to at least look us up and get involved. It doesn't always take money.
Hooksofhope.org.
It doesn't always take money, time, expertise, just volunteers, all those things. But this is going to grow, and I'm just excited to be a part of it.
We have big goals. So, for those who don't know about Hooks of Hope, we provide destination-style fishing events for veterans, for active duty service members, and for children. We not only bring them in for these fishing events, and we happen to live in the southeastern coast, the Treasure Coast of Florida. It's an excellent area for fishing, for offshore pelagics, for inshore game fish, really kind of all of the above. But we not just bring them in for fishing, we also we connect them with mentorship programs. We also connect them with local churches. We connect them with regenerative medical specialists. If there's injuries that need repaired and there's services that they need that may not be available through the VA. So what we're doing, our goal is to encourage, to heal and restore those who are suffering out there. And we need your help in order to do it. We can't do it alone. Our goal for next year, hopefully we're going to try to help at least at a minimum 1,000 people. And it wouldn't surprise me if we're able to help 3,500 or 5,000 people. But I firmly believe that our mission field is all of them. So there's about 8,600 veterans and active duty service members a year that commit suicide. That's an unacceptable number to us, and we're going to put a dent in that. So Brett, what's your approach when a combat vet comes to see you, right? What's the approach that you take to kind of evaluating where they're at and what their needs may be?
Yeah, so just first things first, we're an integrative medicine clinic. So what that means is we're not against conventional medicine. I'm not against pharmaceuticals. I'm not against science. But we want to kind of take a look at the whole patient. So the first question that I ask the patient, and I write this down as my chief complaint, is I say, why are you here? Yeah. What do you want to gain out of the relationship? What are you looking to do? And so that's going to be different for a lot of different people. But that's the very first question I ask. They may say, just everything's a mess, or I can't sleep, and my marriage is on the rocks, and I have no energy, and et cetera. Or they might say, hey, I feel pretty good, or I don't really have nightmares, but I just want to lose 15 pounds. Like, that's going to be different. So that sort of sets the stage as far as what I'm thinking about. And then I just go through your standard basic past medical history, past surgeries, your medications, your drug allergies, your family history, your social history. I'll do an exam. And then I get into a lot of my questions that are sort of specific to different systems. So I'm going to ask them about fatigue. I'm going to ask them about sleep. I really want to get down into their dietary habits. I want to ask about energy. I want to ask about cognitive function. I want to ask about abdominal pain. I want to ask, if they have, various types of GI complaints. Is that related to food? Is it not related to food? Is there something specific that you're eating on a daily basis? So we're going to look at all those things: chest pain, shortness of breath, heart palpitations, blurred vision, so on my intake, there's typically about 50 to 75 questions that I want to ask the patient to kind of really be specific about what we're trying to do. And then after that, generally what I do is I'll do an initial male panel or an initial female panel. But, with combat veterans, mostly it's going to be men. And I'm looking at, here's what I want to address. I want to understand different markers of inflammation. I won't go into too much detail about that, but just different markers of inflammation. I want to look at a conventional cholesterol panel, but then I want to do what's called a cardio IQ cholesterol panel. So with that, that's going to give me an indicator as far as markers of active plaque buildup. There's a couple of different things that are involved with that, which I won't go into detail, but that'll give me an idea as far as where they're at on the potential for heart disease spectrum, and then maybe genetically if they have some predispositions to potential problems with plaque and those kinds of things. Then I'm going to look at all their hormones. We talked about this a little bit before, but just with regard to testosterone, I'm looking at free testosterone, bioavailable testosterone, total testosterone. I look at estradiol. I look at DHT. I look at sex hormone binding globulin, which is something we didn't really talk about, but pregnenolone, DHEA, progesterone, cortisol. Well, that's separate. Yep, cortisol. Yeah. I'm looking at their thyroid. So we talked before: TSH, T3, T4, reverse T3, B vitamins. You look at tyrosine. So, and then if I'm talking to them, we talked about MTHFR. If I'm talking to them, sometimes there are things that a patient's going to tell me, and that tips me off to maybe they are. So I won't hesitate to check the lab for a mutation to that, and there's different things that I can do with that. If their blood pressure is high and they've had trouble controlling their blood pressure, I'll look at a magnesium, I'll look at a renin, I'll look at an aldosterone, just to start. And then I'll look at, we mentioned full hormones, cardio IQ cholesterol panel, all markers of inflammation, and then I'll look at vitamin D, vitamin C. I'll look at an omega-3 fatty acid panel, and then I'll just look at all their conventional labs. And then based on the intake, based on the conventional history and physical, and based on what I'm seeing on the labs, I essentially am going to devise an entire health optimization program that is designed to kind of reverse whatever is going on. So make them more functional right now and start working on prevention. So it'll start with an approach to how they're eating. I don't like to use the word diet. I like to say lifestyle. Yeah. So the lifestyle, exercise, really, right? Exercise. One of the things with the combat veterans, a lot of these guys that we have to understand when we move from age 40 to, let's say, the age of 80, doing that crazy CrossFit workout every day that you did when you were 25, that may not be the best thing to do as you approach the age of 45, 50, 55. And so there's a moderation component. Right? Yeah, well, and then, the sedentary lifestyle is something that we always looked at in the past, but we're starting to look a little bit at the guys that are triathlons, the guys that are power lifters. Some of these guys don't age really well, and the thought is they're creating just as much oxidative damage as the sedentary person.
There's a really interesting book. It's called Eat Meat and Stop Jogging, and it goes through
goes through that. Yep, a lot of that stuff. Like, so moderate exercise. But again, that's all personal. I've got patients that I have guys that come in, people like Fred Galvin, not so much anymore, but he used to, and he'd work out like a maniac. And then I've got people that have never worked out. So generally with a combat veteran, typically the discussion is one of maybe toning things down a little bit as we start to age, with the thought that we're thinking about longevity, and we're thinking about prevention, right? And so then, we're diet. We mentioned the way we're eating, we mentioned exercise, and then sleep and stress. Those are my four cornerstones. And then from there, we work on hormones, we work on insulin resistance, we work on cholesterol, we work on inflammation, we work on joint pain, we work on brain health. Whatever it is we need to start working on from the basis of those four things, we'll start hitting. Okay. So that's generally speaking how we do it.
Okay. So Brett, for the veterans and for active duty service members that may be watching, like, what are three things that you'd like to close with, right? That they should look at that you think will have the most impact, right?
I think that understand, and this might sound like a cliche, but understand that you're not alone.
Yeah.
Understand that there are a lot of guys that are experiencing the exact same things as you're experiencing. Understand that just like in a combat situation, your life, your buddy might be dependent on you for their life. You might be dependent on them for your life. We have to approach things the exact same way in the civilian sector, and also understand this: your life matters. Okay, when people say are out there saying that life is meaningless and all these kinds of things, that is bullshit.
Yep.
You're the only person in the world. You, John Lesnick, me,
That's
Brett
right.
Haake, everybody in this room. We're the only people in this world with our DNA. All right. Your life matters. There is a reason for why you're here. So I would say that would be the big thing is that understand that you're not alone. Regarding practicality, I would say seek out doctors that are looking for these kinds of things. Seek out doctors that are digging a little bit deeper, that are asking about sleep, that are asking about what you're putting into your body, that are looking at your hormones, that are measuring levels of inflammation and all these kinds of things. So seek out, they're out there. The functional medicine doctors, the A4M doctors, they're out there, but seek those doctors out.
Yeah, that's good advice. That's good advice.
So again, ladies and gentlemen, Brett Haake with Hooks of Hope. We appreciate you joining us today, Brett. Thanks for all the data.
Absolutely, man. John. God bless you. God bless
you,
Hooks of
brother.
Hope. I know he's going to do unbelievable things, and this is a great day, and I can't wait to see what becomes of this. We need to just sit back and let God do his thing.
Amen.
It's going to happen.
We're gonna get some snook tonight.
That's it, brother.
That's the plan.
You got it.
Get some snook.
You got it.
Sounds
Let's do
fun,
it.
man. Let's do it.
Perfect.
Thanks, everyone. See you
That's
next
it.
time.